Well, welcome everyone for today's IPEC event. We have a lovely turnout, so thank you so much for coming. Our visitor today, as you know, is Theresa Brown, and I'm just going to take a moment to introduce her. Theresa writes the New York Times column Bedside, which offers insightful and accessible commentary on health practice, policy, and perhaps most importantly, the human experience of the healthcare system. She's the author of Critical Care, A New Nurse Faces Death, Life, and Everything in Between. And raise your hand, all of you who have read that book. Doesn't that feel really good?
It does.
Yeah, and the college fund. Yeah.
Right.
So it's all good. And she previously wrote for the blog Well, that was also in the New York Times. Theresa is particularly qualified to speak to these subjects because she is a frontline worker, clinical nurse in Pittsburgh. And interestingly enough, she also has in her past life, as you say, a PhD in English. So the combination of humanities, the arts, and health sciences really brings vigor and life to the story she tells. So also what I've learned about Theresa is she's really funny, that she's very down to earth, and we all appreciate that. And she's also a staunch advocate for what we're all here to do, to think about adding quality to the healthcare system, reducing errors, and making the care experience come back into the healthcare system. What brought her here today is a column that I and a number of the faculty here read, and we were quite inspired by, Healing the Hospital Hierarchy. And let me just very quickly read you a quote, and then we will get going. She wrote, "Most people in healthcare understand and accept the need for clinical hierarchies. The problem is that we aren't usually prepared for them, nor are we given protocols for resolving the inevitable tensions that arise over appropriate care. Doctors and nurses are trained differently, and our sense of priorities can conflict. This isn't about hurting feelings or bruised egos. Modern healthcare is complex, highly technical, and dangerous. And the lack of flexible, dynamic protocols to facilitate communication along the medical hierarchy can be deadly. Indeed, preventable medical errors kill 100,000 patients each year. The good news is that there are institutions trying to improve how nurses and doctors and other health professionals work together. One bright light is the area of interprofessional education. So please welcome Theresa Brown.
So thank you so much. And I mean, we'll stop round one for questions. Shall I do it? Yeah, okay. And I'm very happy to sign books also, so which I've signed 2 already, so don't be at all shy about asking. I'm very happy to do that. First of all, I'm really glad to be here. The people I've met already at UNE talking about interprofessional education are so thoughtful and so exciting and inspiring, and it feels really wonderful. And you all look so interested and enthusiastic, which may be a facade or just mean you've had a lot of coffee, but either way, I'm glad that you're here. So this is my talk, Revisiting the Bedside. This is who I am, and that's my book, which you've read, so you know. Also, I tend to not end up telling the story of how I became a writer because I'm sort of used to it by now, but I'm happy to answer that in Q&A, and certainly can tell how the book came about and how I ended up writing for the Times. But the reason why we're here, 2 questions. What is the bedside and where is the bedside? Does anyone have any thoughts on this they want to throw out? Anything that these are meant to be sort of no-brainers in a way and then harder than you think in a way also. So what is the bedside is obviously when you're standing next to a patient and they're in the bed, right? That's where the bedside is. But the bedside is also a metaphor, and it's not a coincidence that my column for the New York Times is called Bedside. The idea is that in that space where you're right there next to the patient, you can't ignore what's going on with them. There's a knowledge and experience base that has a tremendous amount of value to giving people good health care. And so that's sort of what the bedside is. But where is the bedside? Seems like an obvious question to answer. It's at the bedside, right? But actually, it's not. The bedside can come with us. It can move around. Basically, what I want you to think about as clinicians is the bedside is something that you take with you, that you want to always think of yourself as someone practicing as being at the bedside, because that's where the most important things in healthcare go on. So the bedside is a place, but it's also a metaphor and a symbol for where we need to be when we're thinking about healthcare, which is to say we need to be with the patient in the bed. Okay, and this is my column. The reason I wanted to put this up here is for everyone, but really for the nurses in the room. This description here was written by the people at the New York Times. I had nothing to do with it, and the first time I read it, I actually got tears in my eyes because I just found it so meaningful that they had given voice to the nurses' experience. And you can all obviously read it, but I'm going to read it too. Healthcare is about more than doctors and patients. Sometimes the best perspectives come from the people who see both sides, the nurses. And here's the bedside piece that I was trying to get at. Bedside probes the complexities of the system within a human context, looking for ways to make healthcare better and more humane. And that's really what my sense of what you're trying to do with interprofessional education is all about. Okay, oops. Well, you can read that still. Okay, so now we're going to start to talk about why do things go wrong. So I've got the MD, RN, physical therapy, social work, aid. There are so many more people I could have put in this list. Respiratory therapy, and even when we were talking, I realized I left out pharmacists, and I thought, oh, I've got to change the slide. And I thought, no, I should reveal to all of you that even though I work with pharmacists every day and value their work and think they're very important, I didn't even think to put them on this list. So it's very easy with so many people working together in healthcare to forget all the pieces. And the real thing here that makes interprofessional education difficult is that it's very hierarchical, right? And this is not a new observation of mine, but I think we all know the sort of captain of the ship model, that's the physician, and then the sort of power structure sort of trickles down, and nurses are somewhere, and respiratory is somewhere off in the margins, unless you really, really need them, and pharmacists are sort of the great unsung heroes of healthcare, in my opinion. I learned nothing about them in nursing school, and they are so fabulous and do such hard work for me every day when I'm at work. And like I said, I even left them off this list. Aides, as we all know, get almost no respect from anyone, and yet they do really, really important work. They can let you know when something's going wrong with the patient. They can be the person the patient talks to at 3 a.m. when their heart is breaking. And so part of what I'm trying to do is say we all have a really important role, even though we work within a hierarchy. The other thing to keep in mind is our patients often feel stuck in this hierarchy also. They're afraid to speak up to the doctor. They then have a million questions for the nurse, but the nurse doesn't have time because she or he is busy doing something else, and then they sort of become afraid of the nurse, and often they are just looking for one nice person who actually has the time to talk to them. So there's a sort of care hierarchy in the hospital, but then there can also be a financial hierarchy. Do they have insurance? Do they not have insurance? Do they have good insurance or do they have bad insurance? Are they on medical assistance? And that can make a really big difference too. So it's easy to get stuck in thinking about, I'm here for the patient, but I'm limited by my environment and the strictures in it, but the patient is also limited or can be limited. And it's really important to keep that in mind as a way to have empathy for patients and also have empathy for ourselves, because both those things matter. So what's the history of this hierarchy? And this may seem like a very, very obvious point, that the doctor-nurse relationship comes out of traditional gender roles. Historically, men have all been doctors, nurses have all been women, or not men have all been doctors, all doctors have been men, and nurses have been women. And this seems so obvious. Why am I even here talking to college students about it, right? Like a 5-year-old could figure this out. But the point is, we have these ideas about men's and women's roles in our head that we've heard since childhood, and the people much older than us in the field also have those ideas and were trained at a time when they were much more fixed. And so you may learn in school that we're a sort of much more free to be you and me way of practicing healthcare, but then once you get out in the clinical setting, you're gonna encounter people who, that's not the way they were trained, that's not the way they experience the world, and it can be a hard shift. So a quick review of the literature. This is not gonna be boring. Okay. The Cherry Ames series. How many of you have heard of this series of books? Dear. Of people. This was a series of books about nursing published between 1943 and 1968. Cherry Ames went many places. This is my personal favorite, department store nurse. I just don't know what the medical needs were in that department store, but they were intense, I think, yeah. She also goes to a dude ranch. You know, this was the crucible of healthcare that Cherry Ames was in the middle of. But a lot of women who became nurses grew up reading these books. And this is an excerpt from Department Store Nurse. It's actually right at the beginning of the book. "All right, Smarty," she said to her brother, "there is someone in my romance department. A handsome young doctor, couldn't be anything else." That's her brother teasing her. "Now, don't tease Cherry about her nursing," their mother said gently. "Anyone who's been as devoted as she has." Okay, so first of all, you've got the idea of a nurse working in a department store. And, you know, the less said about that, the better, right? And then at the start of the book, really, the whole point of Cherry's job is to hook a doctor to get married. And this is a stereotype that perseveres, right? I mean, to the point where in work, physicians I became friends with, people would actually tease me, but say, "Are you having an affair with X?" You know, and it happened often enough with different doctors that it was creepy and a little bit weird, and you know, I'm married, and none of them were really very cute anyway. So no, I'm just you know, but sort of that's even with nurses, they couldn't imagine just that we were collegial friends, and I could talk to these physicians like we work together. Okay, here's another book. So that Cherry Ames was back in the 50s and 60s. This is 1978, The House of God. Have people heard of this book? Yeah. So this is a book, it's a novel based on an intern's experience. And when this book came out, it was amazing, is my understanding. You know, obviously I wasn't paying attention, but it really exposed a lot of the inhumanity of training in medical school. And it's hilarious, it's a caricature, it's also incredibly sexist. And I have a good female physician friend who said she could not read this book because it was so offensive. I mean, I would still recommend it with the caveat that it is very sexist, because it just gives you sort of insight into the experience of medical students, even though it's obviously very distorted. But there are no women who are doctors in this book. But the really terrible thing is the nurses are basically just one step above prostitutes. They don't have any clinical knowledge. Their work is really just to have sex with the doctors. At least that's how it seems from what they do in the book. And the book has no self-consciousness about this. It's not reflective in any way about that. It's just that's the way it is. And people are still talking about this as a really important book. So this is the New York Times, 2009, not that long ago. It's a raunchy, troubling, and hilarious novel turned into a cult phenomenon. Called The House of God. The book was drawn from real life, and 30 years after its initial publication, it is still part of the medical conversation. And in some ways, it should be. It has earned that place. But on the other hand, it's perpetuating these horrible, horrible stereotypes about nurses not doing anything and practicing really just because who would want to do a job when you could just have sex with a doctor, or that is your job. So, I mean, and I'm not trying to be vulgar, but just to say, these are crude. They're crude stereotypes, and they're still getting some traction. And then this is the most painful example. Let me see. Do you know what this is? So, this was part of a Dr. Oz program, November 4th, 2010, and you're really seeing is believing. And let me just preface this by saying I do not think Dr. Oz is a jerk. He blurbed my book. I think he really supports nursing. But you just see what you think after you watch this.
I always say dance is a great way to work out. It's great for your heart, it revs your energy, it boosts your mood. That's why I'm so excited about my next guest. She lost over 200 pounds by dancing. And now she's inspiring others to do the same. Please welcome Angel Williams. Angel. How are you?
It's a pleasure to meet you.
The pleasure and honor is all mine.
Maka loves you.
I got to understand you a little
you notice
bit.
the outfit.
You lost 200 pounds. You're not a choreographer, but you managed to dance away that much weight. I mean, how'd you do it?
You know, Dr. Oz, I love dancing, and so I decided, you know what? Dance in my house, dance while I'm cooking, dance while I'm cleaning, going out with the girls, go ahead on a night out in New York, just get moving. I decided to just keep it moving.
So in the very beginning, because there are folks watching right now say, well, she got done, but it was hard in the beginning, I'm sure. What inspired you?
You know, I was down and out in my life, and I was at a time where I knew that I needed to make some changes. You know, I was tired of getting the doors slammed in my face for my dreams, and I decided, you know what, you've got to make some changes. So I did. I started dancing and moving, and watching your show, you know, you're the doctor that gets us eating right, thinking bright, and I decided to apply all those things to my life. Thank you so much.
I love you saying that. So, I hear you're going to teach me, and I'm serious about this. I learn from you. And the reason I do the show is because when I ask you questions and you answer them, or when you have better questions than I could ever think of asking, I learn from that. So teach me now.
Okay. Do you guys want to join in too? Yeah. Everybody stand up. Everybody stand up. Okay. You know, we're going to get sexy too. We got to, be kind of sexy with it. Get my hat going. So the first move, Dr. Oz, because we're your nurses, we're going to help keep America moving for you, okay?
Oh, I love it.
All right, so we're going to go, we call it the Sean Paul Shuffle. 1 and 2 and 3.
Okay, I think you're getting the point. But it gets to,
on the one,
see, they have,
okay. 1 and 2.
More nurses.
And no turn, baby. 2. Attack.
All right. Now, we got some fellow nurses going to help us, right?
Yes.
I want you fellow nurses coming down. We're all going to do this together. We're going to put them together for a big party. Oh, look at them coming. All right, audience, you ready?
Okay, I'm sorry, I can't watch that again. I think you get the point, right? And again, I want to say, I do not think Dr. Oz is a jerk. I mean, when the offensiveness of this episode was brought to his attention, he released a statement saying, I respect nurses, I've worked with nurses all my life, I look at them as colleagues. But at the same time, he and no one on his show, I mean, this is a well and heavily produced show. Not a single person said, what are we thinking? And this woman's not a nurse. So someone even got that idea. Let's have her dress like a nurse, and then, the whole sexy nurse thing. So I would love to say we live in a world where we're no longer being influenced by these ancient ideas of what men and women do, but unfortunately we're not, and then in healthcare we end up, whether we're conscious of it or not, they influence how we interact with the people we work with. So why do traditional gender roles matter for interprofessional education? The point I'm just saying, they reinforce and give flavor to the existing hierarchy. So what does that mean? That you grow up in a world where we think of men as being in charge, sort of captain of the ship. You know, the captain is rarely seen as being a woman. Women are traditionally subservient, expected to be quiet, not expecting themselves to be in charge. No one else is expecting them to be in charge. And so even though there's more women in medicine now and more men in nursing, we still come out of this history, and it can make a difference. So that's just something for you to keep in mind as you're practicing. The question, though, is the hierarchy, what's the problem? And you already got a description of the column I wrote, Healing the Hospital Hierarchy, where I talked about this. And it would be interesting, and maybe in the Q&A you can share your own thoughts on, is the hierarchy the problem? To me, it's not the hierarchy per se, because healthcare is complicated. It's getting more complicated all the time. Legally, right now, there has to be someone who the buck stops with, in a sense. And the way we run our system is that's physicians, nurse practitioners, and PAs, people with prescribing privileges, are the ones who legally say, we will do this procedure, we will give this drug, we will follow this treatment regimen. That's just the way it works. And I don't have in my head a good alternative to that. I don't know that we need an alternative to that. But we need to be able to talk to each other even though we're in a hierarchy. So it's sort of, fighting about who's going to be at the top of the heap, I would say is less helpful than thinking about how do we all have a seat at the table, just to mix a whole bunch of metaphors together. So the real problem is our inability to see each other as human beings. And I think that's so much of what it comes down to. But then the question is, why does that happen? So I've got two stories here for you to think about. And this just happened to me recently. I was talking with a physician colleague, someone I met at a workshop, and he was telling me a story about he had a patient admitted for surgery who has a pretty serious history of narcotic addiction and knew that the surgery was going to be painful and knew that the patient was going to ask for an escalating dose of narcs. And so he's telling me the story of the nurses constantly calling him and saying, she's in a lot of pain, we need to give her more pain medicine, and him saying, no, we don't need to do that. And what I was hearing from him was his frustration, like, of course the nurses are always calling me and asking me for this, and it's not what's best for the patient. And what I was imagining was the nurses are constantly calling me versus the eye roll, is the nurses rolling their eyes because of feeling so disempowered. Here's my patient in pain. I'm calling this doctor. He keeps telling me I'm not going to give this person pain medication. Why didn't it ever occur to him to explain why he didn't want to keep upping the dose on this patient? I mean, to me, that just seems so obvious. And HIPAA would not keep that information from being communicated. And you could communicate it, and you could come up with a plan, and you could come up with a dose regimen, and it would avoid all these phone calls and all this conflict and feelings on the part of the nurses that I'm not doing my job. And even if it's beyond a level of my patient's in pain and their pain isn't being relieved, that's bad enough, but he may not be aware how much we're evaluated on, are we relieving our patient's pain? Are we taking care of them? Is that patient then going to go to the manager and say, the nurse didn't get me what I needed? Is that, patient going to be complaining to other patients about, at this hospital, I didn't get cared for by the nurses? So it becomes not just a question of taking care of that patient, but a question of professional integrity and even feeling like you will be seen as having done a good job, and all because the nurse didn't have all the information. And the doctor was so completely confident about having the information and confident about not sharing the information, which I find very strange, but not at all unusual, I'm sorry to say. Then the second piece of this story is where I say choosing not to speak up versus speaking like a colleague. I was talking to this doctor who's someone I've just gotten to know, but like, and I did not say to him, why didn't you tell them? And, partly that's not why we were on the phone and we had a bad cell phone connection, but these are excuses. I really, I dropped that ball. And I was thinking about this as I was thinking about this talk and thought, so what I have to do when I get home is email him and say, look, why didn't you tell the nurses about the patient, and say, look, here's the nurse's point of view on this. And that's a lot of what it comes down to. We've got this gendered hierarchy, right, that's from our past about who's in charge, who speaks up, who doesn't. And then we have what we would call siloed systems. That's a sort of management buzz phrase that gets thrown around. But it means basically people are in their own units of practice and don't speak to each other. And the simplest thing would have been for the doctor to speak up. And the simplest thing would have been for me to speak up. And why don't we do this? I don't seem like I have a problem talking, right? But I didn't speak up. So I'll have to let you know how the email goes, right, after I email him. Why does this happen? So it's not just the history we came out of, but big problem is we learn almost nothing about each other during our training. And I was just talking with us this morning about some folks on the other campus that in nursing school we learn almost nothing about doctors, about working with doctors. And even sometimes it seems like there really aren't any doctors. They're just sort of, I don't know, these orders that get put in the computer or these people who walk around in long white coats. And there's not really any talking about how do we work with them. At the same time, what I hear from MDs is they don't get any training on working with nurses. And so the problem is that what nurses end up absorbing is what we see taught to us, right? You can see doctors who are great to work with. You can see doctors who are terrible to work with, in a minority, but they exist. And do you learn from your role models how to appropriately address that, or do we get eye rolling and complaining behind the doctor's back? And if you address it appropriately, would anything happen? There's the reality piece here. Is there a pathway to really making a difference? At the same time, physicians put in these orders and they know nothing about the work of the person who's going to be putting them into practice. Nothing. And this is another really illustrative story. A physician friend of mine, a good friend, read my book, and he said, he's an intensivist. He's been an intensivist for 30 years. So he works in the hospital in an acute care setting very closely with nurses, right? He read my book. He said, I had no idea what nurses did all day. None. And, and that's, again, not to say, wow, what a jerk, he's so blind. No, that's not the point. The point is that we are able to work so closely with other people and yet not have any sense of what's on their plate, what's going on with them. How come I put in 10 orders and nothing's gotten done? And both of us have pressures on them. On us, and I'm going to talk more about that. But that's a pretty amazing level of professional blindness to work with nurses that closely for so many years and just not know what we do. And then the other thing is, again, just the language we use, male nurse, woman doctor, again, goes back to these old idea of gender stereotypes and sort of keep reinforcing them. The idea that a male nurse is unusual because, nurses are about caring and women are about caring, and You've got woman doctor, well, but it's really men who are used to being in charge. And, we think we've passed beyond all these things, but they're there. It's our history. It's how we grew up. And just to give another example of this, the New York Times Magazine just had an article Sunday on women in science and how few of them there are. And my husband's a professional physicist, so he really thinks about this a lot. And they said the overt bias against women is gone, but there's still lots of subtle bias, not getting encouraged, not getting the same level of support that women do. And the higher women go up in the science hierarchy, the harder it is for them to excel. And this has also been noted with women physicians. You have a lot more women physicians, but that doesn't mean you have any more women in these really high positions of power in institutions and medical positions. So it's there. It's sort of like something in the air that's influencing us. So we really, really need interprofessional education for bedside care to work, for patients to get what they need. Obvious, RNs spend more time with the patient than any other inpatient caregiver. This is a fact. It's often, I've heard nurses say this kind of defiantly. There's no need to be defiant. This is a true statement. And it's the way it is. So, but at the same time, almost all inpatient care is directed by MDs or NPs or PAs giving orders that nurses carry out. And my apologies for not including all the ancillary people. It's just too many letters and initials to get out. So I hope if you're here and thinking about respiratory therapy, I should have asked at the start what everyone's field is. But anyway, if you can, I'm not leaving you out because you're not important. I'm just not leaving you out because it's just too much of a polysyllabic mouthful every time. So please try to see yourselves in here. And certainly for all these positions, physicians are still at the top of the heap, and it's still orders that tell us what to do. If we don't fix this, we're going to stay stuck. And this is an article from 1967 called The Doctor-Nurse Game by a man named Leonard Stein, and he analyzed what he called he called it the game, but of how doctors and nurses interact with each other. And the nurse makes suggestions as if her ideas were the doctor's ideas all along. So I was thinking, Mrs. Jones is having a lot of pain. We could put her on a PCA. And the doctor says, that's a great idea. Put Mrs. Jones on a PCA. Do you guys know what I'm talking about? Patient-controlled analgesia, pain pump, like a morphine pump. And the idea was nurses had a lot of knowledge, but didn't have the institutional power and the confidence to say to the doctor, hey, I was thinking about this. She's in a lot of pain. Could we do this? Because ultimately, the doctor's the one who's going to make the decision, but also it's not acceptable for her to just come and say, here's what I think needs to happen. So then, in 1990, Leonard Stein rewrote this article of The Doctor-Nurse Game, and what he saw it being at that time is the nurse is what he called a stubborn rubble. So this time, instead of the nurse saying, I was thinking, the nurse says, Mrs. Johnson is in a lot of pain. She needs to be on a PCA. And the idea was that the nurse feels sort of defensive about having her authority and acts it out with the doctor in this way. And I have to tell you, there were nurses who really, really hated and resented this article. But from my own experience, I've been both these nurses. I've been the nurse who makes a suggestion. It could be because I'm dealing with an intern and they're new to being a doctor and I'm trying to give them a little confidence. It could be because I'm dealing with someone who I know really does not like nurses making suggestions, or anyone for that matter. It's not just nurses. I've also been this stubborn rebel, usually not with the steely-eyed look, but I've certainly confronted doctors, and sometimes it seemed like that was the only way to get things done. and everything in between, most likely, right? But so what's missing here, obviously, is just being able to talk to each other like colleagues. And I'll tell you another story. Trauma room surgeon at Stanford who talked to me, who also is a medical device manufacturer, and he said, this is the first time I wrote about physician bullying. He got in touch with me, and he said he cannot believe the difference between the environment and level of civility in the trauma ER and in his device manufacturing business, where in the business world, it's not allowed for people to yell at each other, to throw things, and these behaviors are just completely tolerated in the trauma ER. And, yeah, there's a lot of stress and people's bodies have been torn apart, and that's very, very difficult. But the point he was making to me was there is a level of expectation of behavior. And so that's talking about, we just need civility. And what I'm talking about as importantly, and we need this is probably maybe harder to achieve in some ways, is collegiality, seeing each other as partners. We're all partners in the care of this patient who's in the hospital. Okay, there are key things that nurses and doctors need to know about each other, and actually this applies pretty much to anyone right now working in the US healthcare system, whether you're a social worker, a physical therapist, a respiratory therapist. All of us are too busy. This is number one. Is there anyone who's seen the working healthcare system, you've been somewhere and you feel like, wow, everyone here really has enough time to always do what they need to get done? Yeah, wouldn't that be nice? Yeah. So we're all just a little bit busier than we should be. Sometimes we're a lot busier than we should be. Everyone, it's so the person who's ignoring your page, it might be because they're a jerk. It's probably because they're too busy. The nurse who hasn't carried out those 10 orders that got put in, it's because she's dealing with someone who's projectile vomiting in the next room. The physical therapist who can't come up and help you get a patient out of a chair, who's very heavy and you're worried about your back, it's because they have rounds to fulfill and they're not getting them done, and they won't get them done if they come back to your floor when they were already there earlier in the day. So we're all just too busy. The other thing is ignorance precedes learning always, and I feel this most strongly as a message to nurses, because I feel very critical of how hard nurses can be on interns and residents. And I think it's just an example of sort of kicking things downhill. You can have attending physicians who are rude, and then nurses see an opportunity to sort of get some payback with the new doctors, and you just end up getting this horrible, vicious cycle. And everyone picks on medical students. That's what I've learned from the comments to my columns. They just feel like nobody has any respect for them, including housekeepers, which is really sad. So we all come in not knowing things our whole lives. There are things we will not know. And the opportunity to teach someone something is a gift and so much more important than condescending to them because they don't know something that you know. There's things all of us don't know. And I always look at learning as an opportunity. And it's also a way to build connections between fields. Stress makes mistakes more likely, so if someone's yelling at you, you're more likely to, screw something up in a way you never would have otherwise. That goes for all of us. Being kind is never misguided. You're like, Theresa's telling us things we learned in kindergarten, right? But it's sometimes really hard in the healthcare environment to be kind, to remember that. It's a way of seeing everyone with you as another human being. And just to be kind, to give people a break. Do I always do this? No. Is it always possible? No, because we're all human, but it's something to aim for. Condescension is corrosive. By that I mean that if someone's condescending to me, it makes me more likely to be condescending to someone else. It makes them more, it just sort of goes on and on and on and on and on. And that's really about setting expectations. only yell in an emergency. This is the interesting thing I found out. If you look at situations in healthcare where people are being abusive to each other, it's usually not because someone's arresting and everyone's panicked. People know what to do in those situations, usually, not always, but usually. It's other stuff, which is probably a response to that stress of that situation, but it's not actually in the moment. And that's what this trauma doc told me too. It's not that someone comes in and everyone's thinking, oh my God, how are we gonna save this person? It's the moments around that, having that patient in there. And so, that could be a whole nother talk about how we need to all work on ways to de-stress because of the really tough things that we see. And then listen as much as you talk. I was gonna say listen more than you talk, and I thought, no, sometimes you need to talk, but nurses need to talk, doctors need to talk, PTs need to talk, but try to listen as much as you talk. Talking's easy, listening's harder. And most of all, we're all human. We all want to do a good job. And I find this to be true across the board. You'll hear about arrogant doctors who don't care about patients, lazy nurses, incompetent so-and-sos, blah, blah, blah. There are people in every walk of life who are not that committed to their work. But what I see in healthcare in general is really, really hard-working people who go without meals, who don't get bathroom breaks, who work really long hours, and they do it because it's very meaningful work and they think that it's important. And that's maybe the biggest and most important message I can give you, is to remember we all want to do a good job, and that person who seems like they're just fumbling and incompetent and can't get it together, they really want to do a good job. They're just in that moment failing. And again, that's an opportunity to reach across the aisle. If you have time, right? That's the problem. You don't always have time. So what barriers do we have to collaboration? It's wonderful to be in a classroom setting and do role plays and talk about this, and then when you get out into the clinical world, it's different because not everyone there has been through the role plays and heard the lectures and knows how important this is. So first of all, again, historic power imbalance that comes out of gender roles, but also, we know this. Physicians tend to earn more money than almost any other hospital personnel, except for perhaps now administrators, and also have more employment power, even though nurses, PT, et cetera, are hired and fired by nurses. What I see in practice is, and I'm not saying in my practice, but what I hear from people is still if a physician has a hard time with a nurse, often nursing will not protect that nurse. And there was a great example of this in Nurse Jackie, which I know that show's problematic. I actually really like the show, even though I know it's problematic. But I think it was the end of one season, the head of the ED says, to Edie Falco's character, "You're fired." And she says, "You can't fire me. I'm a nurse. Doctors don't hire and fire nurses." And he says, "I'm the head of the emergency department. I can do whatever I want. You're fired." And she does get her job back. But it was a really great moment for this TV show to capture this tension. Who's really in charge? And who's really in charge is very complicated, not just because of power structures, but because of the work that we do. Physicians are putting in orders. I'm making those orders happen. There are nurses who hate that description of our work, but to put it as simply as possible, that's what's going on. And so is the physician my boss? Well, no, the physician's not my boss, but the physician's telling me what to do and can have thoughts on my performance. And this is just something that we have not addressed very well. We really haven't. And so I would be aware of it, think about it. The other thing is a stressed system. And it's not lost on me the irony of being here to talk to you about interprofessional education when our government is shut down because Our politicians can't talk to each other anymore. So, it's not just in healthcare that people have trouble reaching across the aisle, obviously. But the system is stressed with, meaning there's a push to serve more and more people, focus on the bottom line. There are hospitals that are making money hand over fist. There are hospitals that are barely surviving. There are patients who have great insurance. There are patients who have medical bills that are bankrupting them. There are so many factors in play and such a complex level of disturbance at so many levels. And with the Affordable Care Act starting up, no one really knows what that's going to lead to, right? Is the system going to be flooded? Are we not going to have enough primary care providers? It looks like they've got the glitches in the website fixed from what I heard, but even that at the start was just, is the website even going to work to let people sign up for insurance? And obviously, since the government is shut down fighting over the Affordable Care Act, just the issue of health care is very, very stressful for us as a nation. And that's reflecting, all the things that are going on in healthcare right now that are difficult. So I'd say also another barrier to collaboration is poor understanding of roles and responsibilities. And I wrote the POOF Factor because in the column I wrote Healing the Hospital Hierarchy. I talked to a physician at UVA where they also do IPE, and she said that a lot of doctors believe in what she calls the POOF Factor, which is I type an order into the computer and poof, it gets done. And I thought that was really great, just to say there's not a lot of thinking on the physician part of who's actually doing this and what's involved in it. And, this can play out in ways big and small. I remember a patient once who was getting tons and tons of, I used to work inpatient stem cell, and those patients are very, very sick. And occasionally you have people who really have more IVs ordered for them than you can get in, it seems like, in the times available. And this is a patient who for several days had been getting a dose of antibiotic 3 times a day through each lumen of their triple lumen catheter at a certain time. And it was really hard to work all the other things that she needed around that. And it had been long enough that the time for that protocol was done. And so I went to the intern and I said, would we be able to stop doing this? And, well, why? Didn't really seem like a problem one way or the other. And I said, it's really hard to get in all the IV meds when we've got this to do every 4 hours or whatever it was. And it just had never occurred to him, that you have limited access and you have to hang things and it takes time for them to drip in. And not because he was stupid or didn't care, it just is not knowledge he had about how the work gets done. And I think there are probably a million examples of that. And, certainly I have learned a lot from talking with doctors about what they're up against. But starting as a nurse, I really didn't know that much about what they have to do, what pressures are on them, what they have to be thinking about. So then I wanted to say how nurses see ourselves and how we'd like MDs to see us. And this is something that all of you can do. And again, substitute respiratory, physical therapy, whatever your role is. First of all, interpreter of medicalese. So we get sort of physician language up here, right? And then the rest of us who are explaining, here's what this drug does, here's why we're doing this procedure, here's this regimen, here's why I need you to stand up. And I just, recovering from a shoulder problem. So I'm immersed in PT right now. Here's why you're lifting a weight like this. And so that's a very, very important role. Doctors are more and more and more rushed. Patients are understanding less and less and less of what we say to them and what goes on. So that's a very important role. Also, we're an early warning system. It's the nurse or sometimes even the aide who goes in the room and says, wow, something is really wrong here. I had a patient I had started on a monoclonal antibody. It's a drug people can really strongly react to, and the aide came and said, his heart rate, he says his heart is racing. And I just knew because of all the other stuff that was going on that was really bad, and it was really bad. But we kept him out of the ICU, so that was good. So aides, they're taking the vital signs. They can see how someone's doing. They'll know if someone's suddenly confused. And it's the person at the bedside who's seeing the patient, tells the next person, makes the phone call, sets the whole system in play. Every single one of you has potential to be a hero in this way. It's an unsung role of those of us at the bedside, but it is real. And I don't know if have you heard of this concept, failure to rescue? It's the idea that a patient was developing a more serious problem or decompensating, whatever phrase you want to use. Someone picked up on it, usually a nurse, and stopped it. And they have data on this for surgical patients. And when there are fewer nurses, failure to rescue is less likely to happen. So people end up going all the way and crashing instead of having that process interrupted and them stabilized, because there isn't someone to say, there's something not right here, and then set the things in motion to take care of that. So we are a person, not a delivery system. This gets back to the POOF factor. I am not a POOF factor. I am a person with only 2 legs that can only be in one place at one time. I do occasionally need to eat and go to the bathroom. So, and doctors are the same. They also can only be in one place at one time. They also need to eat, etc. Above all, a patient advocate, and this I know this is something that nurses really, really embrace, and we're taught this in school. And what this means, again, is you are the person there with the patient, speaking for them. They're in pain, they're vomiting, they don't understand, they're confused, all of those things. The important thing to keep in mind, and I've learned this from my comments, is doctors will say, why do nurses always have to say the patient advocate? Like, I'm a patient advocate. I do X, Y, and Z for my patients. And I realized, I made that sound snotty. I shouldn't have, because they're right. Nurses are not the patient advocate, but we are a patient advocate. And to set ourselves in opposition to physicians around that role is not necessary, and it's not helpful. There are tons of MDs who advocate for their patients in all kinds of ways. The thing to think about is, in what ways are we the advocate? And again, it's that close connection with the patient. It's the person who's there with them. So not better than what MDs can do, but equally as important. So this is what I would like to see for the doctor-nurse game 2013. And the main thing is, it's not a game, right? It's not a game. And that language was used to say there's psychological interaction going on here that plays out. Like, instead of having a collegial relationship, it plays out like a game. And there are rules that are unspoken, but everyone knows what they are and knows what their rules are. So the thing is, it's not a game. And when you call it something like interprofessional education, that's what you're saying. This is not a game. This is real. This can be part of the curriculum. It matters. It makes a huge difference. So I've said this already. Physicians and nurses are colleagues. There may be someone who is the final decider, whose name goes on the script, but we each have a very important role to play and important things to communicate. Don't let anyone tell you you're just a nurse. There is no such thing as just a nurse. You're a colleague with physicians. They may not always treat you like that. Doesn't mean it's not true. Never, ever forget that. Professionalism and civility are paramount, and this is when I again said that you can never go wrong to be kind. It's very hard when you're stressed to always be polite, to be civil, to not get mad at people. Really, really try to model the behavior you want to see in all of your colleagues. It's not always easy, but try. And I will tell you that one thing I've learned from nurses is the power of venting, which, I grew up Southern Missouri, sort of like you kind of hold things in, and but I've seen in nurses, something happens at work that just drives you crazy. Just I have to vent. Here's what happened. Here's what I said. Here's what he said. Here's what she said. Okay, I'm done. And there can be real clinical value to just getting something off your chest, and then saying, okay, now I'm going to go back to my civil professional mode. And then you can also think about, what could I do about this in my institution? Is my manager sympathetic to what's going on here? Do we have a physician champion who works on these issues? What steps can be taken to, as a system or an institution, work on and promote civility? And, every change has to start somewhere, right? It can be with you. Okay, team medicine is the practice model. We all hear this. It's a buzzword. What does it really mean? The idea of, like I said at the start, knowing who all the players are. And as I also said at the start, even I am guilty of forgetting people. So it's hard. It's hard to keep that in mind, that we all have a piece. And the sicker someone is, the more people are going to have pieces of them. It doesn't mean healthcare has to be fragmented. I think that has what has worked out a lot. It can mean that healthcare is great, but all those team members have to talk to each other. And finally, good communication is essential for good patient care. And this is obvious, right? And also really, really hard, because I can put this up here on a slide and tell it to you, and I hope be inspiring. But that doesn't mean that I've snapped my fingers and suddenly we are all going to communicate well together. I wish I had that power, right? Because then the government would also be reopened. But I don't have that power. But if it is a wish that we all have and take with us into our practice, it can make a difference. Just that impulse to, like I said, reach across the person and say, wow, I see that you're a human being too. Let's do this together. Let's make this work out. If RNs and MDs and everyone else who takes care of patients don't talk to each other, we can't guarantee good care. There is now data that tells us this. It is known that we need communication to do the best we can for our patients. Think of yourself at the bedside if you forget why this matters. And that's what I said at the start. The bedside comes with you. The bedside is always in your head. It's part of you as a clinician. That's where the action is. And finally, the last thought. The most important person in any hospital room is the patient. If you never forget this, you will always do well in providing care. Thank you so much. And I'm always happy to hear from people. I try to write back to all my emails. I don't always, but I do read every email. And, people who don't hear back from me, I may read your email, and it may be something I'm really, really thinking about that makes a big difference. So if anyone decides to write, don't think, well, she never wrote back, she didn't care. That's not true. It's just because I'm busy and have 3 teenagers and, life.
We are live streaming, so if you have questions, I'm going to rush at you with the microphone. I apologize, but please do take advantage of this time to ask Theresa questions.
Or comments or thoughts or anything.
Oh. I'm getting my workout for the day.
Wondering if you would comment on the hospitalist movement. I've heard that hospitalists sometimes, because they don't know the patient before patients are hospitalized, that they're not bringing the patient's values that they know of beforehand to the bedside. And yet I can also hear from your talk that maybe there's an opportunity with hospitalists, that there is more opportunity to strengthen or improve the relationship between doctors and nurses in hospitals. And so maybe that is helpful with the relationship with the patient. So I'm just curious, in your experience working in hospitals and having seen the hospitalist movement grow, what has your experience been? Do you see those same pros and cons, or do you see it more in one direction or the other?
Oh, that's a great question. Thank you. So does everyone know that this movement to have hospitalists who are experts, MDs and DOs, I guess, who are experts in hospital care, and the idea is with restrictions on, and if you have to go, thank you for coming, and I know you're all busy, so. Thank you. Oh, I didn't mean you all had to leave. Oh, okay, gotcha. Fair enough.
So we have a question up here when you're done.
Oh, okay. So with now that interns and residents' hours are more limited, what's happened is attending physicians have had to pick up a lot of that slack, and they don't really want to do that because it's not because they're lazy. It's just a lot of hours, and so that's partly why we've seen the rise of hospitalists as physicians who will work in hospitals and they provide coverage. So they end up being moonlighters. They end up being sort of floaters for, say, practices that have admitting privileges, but they don't have someone in the hospital. And what I have seen among hospitalists is a strong kind of pass the buck mentality for big questions. Sort of, they want to deal, if there's any kind of acute problem, they want to deal with it, and anything else gets put off till the real doctor comes in, because they don't know the patient and don't know their history. Having said that, that is a great opportunity for nursing, for nurses to be seen as a liaison with hospitalists, and I know this person, and here's the issue that's going on. And then what we have to have is an empowerment made possible from attendings, because the hospitalists, I mean, this came up for me in a very specific way, a question about end of life, an oncology patient who wanted to fill out a DNR. Does everyone know what the do not resuscitate, do not intubate order, and which was appropriate, and the hospitalist just did not want to go there and would not do it. You know, this can wait until the morning. And what we were worried about is this person going to crash during the night, end up in the ICU, which is not what they wanted, and die with tubes stuck in, you know, every orifice in their body. That did not happen. So that was good. But it was very, very frustrating, because the feeling was of the hospitalist was, I'm not getting into this. Because this isn't really my turf, it's sort of a turf issue. And so that would have to be worked out. And, you know, the Institute of Medicine report about this level of our practice, I mean, that would be an excellent, excellent way to put that into practice, to have the nurse be the liaison. So it's a lovely idea. I think it's, you know, we've got this new way of physician practicing in hospitals. Is there a way to have nurses work with that? I'm going to file that away. Thank you. Yeah. So you have a question, yeah?
Good afternoon. My name is Elizabeth McClellan, and I'm a registered nurse. I'm also the founder of an organization called Partners for World Health that many of the students here know about in Maine. But I wanted to comment on two things. One is communication. When you talk about good communication, it's so essential no matter what part of the profession in medicine and nursing and physical therapy that you're involved with. It's really essential. And I've always felt that part of that communication strategy should be, how is that other person going to perceive what I'm saying? Because so many times we feel like we have communicated the right information, but did they really perceive it as a learning experience, or did they really understand it in the long run? So it's the perception of what that other person said, of what you said and how they interpreted it, that's really important. Not what you said is just as important, but it's how they perceived it. So that I've always kind of enrolled in my practice. The other thing is that when I've reached out to nurses in our state and in other places in the country and in the world, I've said to them, well, what do you do? And they say, my job is a nurse. And I always respond to the fact that it's not our job. It is more than that. It is our profession. And I really feel that we need to speak up about our profession as registered nurses because we need to raise the bar.
Oh, thank you. Great comments. Yeah, tone is really, really important. Really, really important. Really as important, right, what you just said as what you say makes a big difference. Yeah, hi.
Hi, thank you. Thanks for a wonderful presentation.
Oh,
I
thank
read
you.
your book. It's great. And I'm a nurse. I'm a registered nurse and a nurse anesthetist. And the IOM report came out, and everybody's talking about all of our professions practicing to the full scope of practice to try to alleviate some of the problems with healthcare. But not a lot is changing since that's come out. Especially in our profession, we go up against our anesthesia colleagues, head to head. And when it's very clear that there's definitely room for everybody, and I think with all of our professions, it's the same. What do you see from your research and talking to a lot of people? Do you see this changing with the Affordable Care Act? Do you see it changing in the near future and the long future? What are your thoughts?
I do see it changing. My hope is we will first see it changing for family nurse practitioners in the primary care arena because, and this is just a numbers problem, for the expected need, we do not have enough people able to provide primary care. So someone is going to have to do that, right? And there's all this data now that shows that family nurse practitioners or nurse practitioners give as good as or better care in the primary care setting than family practice physicians or internists. That's known. There may be people that argue with it, but it's not like I'm telling you some new bit of information. This is established through research. The question is, are physicians going to allow that? Because nationally, nurse practitioners have been trying to gain more authority. And I'm in Pennsylvania where the role of the NP is pretty strictly limited. There's always pushback from doctors. And the thing I don't understand, not to slam doctors, but is a lot of them aren't going into primary care, but then they don't want nurses to be able to do it. I understand that from a human perspective. Like, you don't want to give up your hold on that job and that authority and a sense that it's important to have a doctor in that role. But at the same time, if we need people to provide primary care and there aren't enough of them, and there are really sort of hard limits right now on the numbers of doctors we can produce. I don't know if people know this, but the funding for internship and residency programs hasn't expanded in 10 years. So we need more physicians nationally, and it's partly just a funding problem. So something has got to give, right? And I think what's going to happen is we will see the NP and the nurse anesthetist and the nurse midwife role expanding, but it's not always going to be easy. And I got into nursing because I was pregnant with twins, and I had midwives, and I really fell in love with their job and talked to them about it. And they were great, and they worked in a midwife physician practice, and but she said there's always conflict, even when we get along. There's always arguing about whose patient is that, and but people can make it work. So it's finding ways to make that work. And also, I would say, focus on the numbers. There's need. There's not enough people to meet it. Who's going to meet that need? Yeah.
Hi, my name's Bianca, and I'm in the accelerated nursing. So you brought up the hospital hierarchy quite a bit, and I'm just interested to kind of hear what you think about that, because I'm sure we all have our kind of personal beliefs and ideas around it, and like you said, the buck kind of has to stop with someone, but then like on the other side, there's been a lot of successful business models that have kind of done away with that and been really successful. So just wanted to kind of hear like what your thoughts are. Do you see kind of any radical change happening around that, or just ideas, I guess?
Yeah, that's I honestly don't see radical change happening soon. Doesn't mean that it shouldn't. I just don't see it happening. I think what I end up focusing on a lot is legally what's going on. So there's, all of us who practice are licensed by the state, and the state sets a scope of practice. And I think people who aren't in healthcare don't always understand what a difference that makes. That, you have to have a license to practice. You'll all be taking the NCLEX and getting your license. And then there are certain constraints on that license, and you can lose your license if you don't follow those constraints. And so it's a very legally circumscribed job for all of us. And I mean, even beauticians they're not called beauticians anymore, are they? There you go. Yeah, right. Have licenses. So there's that piece of it. So you'd have to get at government level changes in official scope of practice. The other question, which is very vexing, is liability issues. And I think the sort of double-edged sword for MDs is being the person who makes the decisions, and they have the authority, but at the same time they are liable. And I'm very sensitive to this because it's the kind of thing MDs will write about when I write about hierarchy issues. Not that they always come across as super nice people, some of them, but just the fear of being sued over a bad decision. And they'll say, if a nurse tells me to do something and I do it and it turns out it's wrong and then I get sued, I'm the one who loses my license, who gets taken into court. And I think that makes it really, really hard. So one thing we might have to have is a sort of team model of liability. I don't know, maybe the hospital needs to be liable for creating a situation where you had a really, really bad outcome. And that's, obviously far outside my scope of work. I'm not a lawyer, so I don't know much about that. But I think that really makes the whole thing very problematic because of everything that goes on over malpractice issues. But it's not, real malpractice should be addressed. Someone who's coming in drunk or just as incompetent, or, those are bad things that should be dealt with institutionally. But then sort of a system problem where you end up with a really bad outcome. Well, was it because of someone who didn't know how to do their job, or this thing got missed and this and this and this and this, and it just gets pinned on the MD. So fault, responsibility, liability, all those things would have to be worked out. Not that they can't be or shouldn't be, but I'm not sure it's going to happen soon. But we can still all talk to each other and have input. And, there's also business models where there's still a boss, right? We all still have a boss. And you can have a boss and still have everyone working collaboratively. You can have a model where everyone can give their input and the person who ends up being the decider decides. And there's enough respect among everyone that even if you don't agree with that one decision, you can still respect that person as a colleague and respect their decision, even if it's not the decision you would have made. It's hard, though, because these are life and death questions a lot of the time. Patients can, different patients can want very different things. So it's a really great question that needs a lot more thinking, I think. Yeah.
Thank you. Hi, my name's Stephanie LeBlanc. I'm part of the PA program. And going into a field as a mid-level provider, talking about that sort of liability, as PAs, we hear a lot about job satisfaction. It's one of the things that drew a lot of us to the profession. Mm-hmm. And I think part of that comes from that shared liability with a physician, because it automatically, when you walk into that position, there is a mutual liability, there's a mutual respect, and there's an automatic
line of communication that has to remain open because we're operating under somebody else's license, but we're also in a position to make definitive decisions. So I'm wondering if you can speak to sort of the mid-level provider in dealing with nurses in that same realm?
And you mean not just liability,
But yeah, as a mid-level provider, we're not necessarily the buck stops here, but we are filling that role a lot of the time. How does that sort of in the hierarchy put us? How does that line us up with nurses and other?
Right. I mean, what I see and experience clinically is that nurses get along much more easily with NPs and PAs. I think there's not that the training's different. It's not that same sort of sense of, I guess, professional impatience, like, oh, can I go up and talk to the attending, and that maybe knowing that NPs and PAs chose this role like nurses where the buck somewhat stops with you because you have prescribing privileges, but not completely because, like you said, you are licensed working with someone else. So I think bedside nurses tend to identify with that role and talk more easily and can have more conversation. And that might be a way into, maybe mid-level, which is, I really don't like that label, but I understand it, but, it could be seen as a sort of a mid-level in communication also. And instead, I think it sort of feels like often it's the nurse talking to the NP or the PA against the doctor, and that's not so great. It's disempowering for both. But if those people could also be rolled into the idea of the team, that could really make a big difference because in a lot of ways you're functioning much more in a physician role. I would say in a lot of the really key ways you are, and that could make a difference. I hadn't thought about that before. That's a great question. I'm not sure I answered your question, but now I have a thought in my head, so okay.
Thanks.
Do you have a question for them?
Can you just tell us how you did get into nursing? You mentioned the twins.
Oh, sure. Yeah, so I got my PhD in English and had we were living in Boston. I was teaching at Tufts and had a slow falling away from academia and just realized this really is not how I want to spend the rest of my life. Me personally, my husband's a professor, so I'm always quick to say, just for me, that's not what I wanted. And then I had my son, and then I got pregnant with twins and had midwives. And when the girls were and they're 14 now, my daughters, when they were about 18 months old, I guess, we had a friend visit, also named Theresa, who's a nurse, and I will, it's one of these life-changing moments. We were sitting outside, the girls were running around, it was very sunny, these two little blonde heads, and I told my friend, I just thought the midwives had the coolest job in the world, and she looked at me and said, Theresa, you could do that job. And it had never crossed my mind. Because I thought the only people who became nurses were girls who read all of Cherry Ames when they were little. And I just had never thought you can go to school, become a nurse, and then I looked into accelerated programs and found out, wow, there's not just can you go to school and become a nurse, but there's whole programs for people like me. And once I got into nursing and learned more about nursing, I found out that being a midwife is a hard life, especially with 3 kids. And I also just really fell in love with bedside nursing. And what I love about it is being in that liminal space where you do have to know a lot, clinical knowledge, you have to be assertive, you have to be able to talk with physicians. You also have to be able to go in and hold someone's hand and hear about what's going on in their life and even help them go to the bathroom. And, I think it's a job where you really are with the whole person, and there can be moments when it just feels really hard and exhausting, but I still definitely get those moments where I feel like, wow, I'm so lucky that I get to be so intensely close to people at these really hard moments in their lives. And I just find that so meaningful. And then the writing that I'm doing now is very different from academic writing. I mean, it's much more personal and it doesn't have all these academic requirements. And I feel like it's about stuff that's really, really important to me. And I mean, literature is important to me, but not in the same way that getting people good health care and taking care of them is important to me. So, yeah, I landed well. And people say, oh, do you wish you'd become a nurse when you first went to college? And I don't know, I can't answer that. I wouldn't be the same person. You know, I also feel lucky I got to spend 6 years reading a bunch of books and writing about them, and that's, you know, that's pretty nice. And I get these 3 letters after my name. But, you know, I'm just glad I made it here finally. Anything else? No? Let me just, thanks for having you. It's so exciting to see the work you're doing. It really, really is. And good luck to all of you.